So I'm happy to have a visiting speaker from the Division of General Internal Medicine this morning, and then followed by Dr. Rodriguez. But we'll start with Dr. Jamie Darnton, who's a clinical assistant professor in the Division of General Internal Medicine. He works at Harborview, did his medical MD training at UPenn, did his residency here at University of Washington, where I had the pleasure of crossing paths with him, and has been here working at Harborview with a specialty in addiction medicine. And we're really happy to have you, Jamie. I'll turn it over to you.
Great. Thanks so much. Thanks, Kate. I really appreciate the invitation. It's great to be with all of you and see some faces of names I know well from the chart, but I haven't folks I haven't really interfaced much with. So really happy to join today. Like Kate said, I'm a primary care internist at Harborview Adult Medicine Clinic, and I've worked for the last couple of years at Evergreen Treatment Services in addiction medicine, treating folks with opioid use disorder through the opiate treatment program system, and I was challenging myself to leave my comfort zone and really think about this population that we see on the addiction treatment side of things with increasing frequency, folks with co-occurring serious addiction and advanced chronic kidney disease. I don't have any financial disclosures. There are some pictures of drugs and drug paraphernalia in these slides. I want to thank Vincent Reichel for some of the slides around the illicit heroin market that I'm going to use. And my only other disclosure is just that these are obviously very complicated patients, and I'm hoping as more to hold space and reflect than to provide any concrete answers for some of these challenges, but I do hope to give an update on some of the opportunities that I see on the addiction side of things for helping folks with serious medical illness and addiction. So I'm going to talk a little bit about epidemiology and the interplay with the illicit opioid market and how the opioids that are available and really come to play when it comes to medical sequelae and renal sequelae of opioid use. Talk about some of the management challenges of folks with advanced CKD who are also struggling with substance use disorders, particularly opioid use, and some of the kind of refresher on some of the opiate use disorder treatment options, and then some of the regulatory changes, many of which sprung out of the COVID crisis that really allows us more opportunity to kind of engage folks in treatment for substance use disorders. Jumping right in, heroin was a very common illicit opioid for much of the last half century. It was marketed by Bayer Aspirin at the turn of in the 1890s as a cough suppressant. I kind of like this quote from Encyclopedia Britannica. It captures the way it was marketed, which was as a safer version of morphine. Essentially, it's something that was good at suppressing coughs, as indeed it is, without the narcotism following upon the administration of morphine. It was as a byproduct of the Harrison Narcotics Act in 1914. It was only available through prescription for registered physicians, and then it was banned in 1924. So heroin and kidney disease. So users of illicit heroin have, any number, a variety of patterns of kidney injury. A lot of it connected to the route, as we'll see, and of use, and folks with some of these complications of IV use can develop kidney disease related to septic emboli, infection-related glomerulonephritis, Hep C, Hep B related kidney disease, and HIV nephropathy and AA amyloidosis. I want to take a little more time to talk about those two conditions because these are in our region. HIV nephropathy, in fact, HIV among people who use drugs is there's a lower prevalence than nationally, and a higher prevalence from what we know of the data of amyloidosis, secondary amyloidosis, and that really stems to this kind of the vicissitudes of the illicit market and what opioids were available where. And just a brief primer, and again, this has really been upended in the last 5 to 7 years as fentanyl has largely supplanted heroin in the illicit market throughout the United States. But until that time, really had 4 regions of opiate cultivation and heroin production. And in each region, there's slightly different characteristics of the predominant heroin produced. The Golden Triangle of Burma, Thailand, and Laos produced this white powdered heroin, very water soluble, that for a time, this is the heroin that a lot of veterans in the Vietnam conflict were exposed to. And it did for a time represent a pretty big portion of the heroin available in the US in the 80s. And then in the 90s and beyond, it really supplied markets in Australia and Canada. The Golden Crescent, Iran, Afghanistan, and Pakistan produced a brown powdered heroin. This is characteristics of this one are it's heat stable, and it can actually sublimate, so it's used inhalationally largely, and this is so a large supplier for the European market. Colombia really moved into the illicit market in the 90s and rapidly increased their production, and were really supplying the area of the United States east of the Mississippi. And again, their product primarily was a brown powdered heroin, water soluble, acidic, and used primarily by injectional route. And our region and most of the I-5 corridor in the West Coast was supplied in the 90s increasingly by Mexico. And the product is this black tar heroin, and it's worth taking a little time to look at some of the characteristics of that, because it really has these consequences as far as the medical consequences that long-term users can face. So, its solubility characteristics require heating to place it in solution, and heating can be protective against less hardy viruses like HIV. The viscosity of black tar heroin means that flushing of a syringe, if it's going to be reused, often has to be done once or more times, which is thought to be protective against HIV transmission. But its acidity, causticity to veins really causes folks who are using intravenously develop sclerosis and a loss of venous access. Some of these ethnographic studies indicate that it happens pretty early on in the history of someone who's injecting, as early as 6 months. And leading to patterns of increased intramuscular use and skin popping. And that route of use is a setup for increase in skin and soft tissue infections, abscesses, and cellulitis. And of course, we've seen from some of the work out of this institution and elsewhere that chronic inflammation associated with these frequent and recurrent suppurative infections can lead to acute phase reactant production in the liver of the amyloid A protein, which forms the fibrils which deposit in the kidney. So just looking at the geography, this is a study from 2003 looking at the prevalence of HIV in IV drug using communities and men who have sex with men communities in different cities in North America. And the states in black, the primary heroin available in the illicit market there is black tar heroin. And with the gray, it's a powdered heroin. And I think it's instructive to look at Seattle and Vancouver, 2.5 hours away, similar metropolitan areas, but because of the border, real differences in what heroin is available. And as we saw, black tar heroin in the early 2000s was the predominant heroin available in Seattle, and it's a soluble white powdered heroin was available in Vancouver. And if you look at the HIV prevalence rates at that time, comparing the two, it was really almost a tenfold difference, 2.4% among people who inject drugs in Seattle, and 23% in Vancouver. And similarly, we don't have as much data, but I think folks who've worked in nephrology or done training on the East Coast, from what I hear, it's vanishingly rare to see secondary amyloidosis associated with heroin use, and it's quite common occurrence out here. This study, I forget the year, 2016, looked at a number of biopsies out of UCSF, and 6.6% had amyloidosis on the biopsy, and the majority of those were diagnosed with secondary amyloidosis. And the kind of control sample taken from biopsies performed at the same time in Chicago, there were no cases. So it again kind of hammers home this point of the geographic variability of some of these consequences. And in some areas, it's clear that amyloidosis is really the leading cause of end-stage kidney disease among people who use drugs. This was a study out of Frankfurt, and fully 50%, the majority or half of the biopsies among folks who inject drugs and developed end-stage renal disease, the diagnosis was amyloidosis. This is another study looking at biopsies among people who inject drugs in Bristol in the UK between 2003 and 2016. There were 23 cases, only 17 underwent biopsy. 15 of those 17 were diagnosed with amyloidosis. So I'm not sure what the predominant heroin available in those communities are, but the prevalence of amyloidosis is quite high, and you can see from some of the data about their, other details about their admission that skin and soft tissue infections are pretty common among these groups. And so we've talked about heroin, but what about fentanyl? Fentanyl, as folks know, has pretty much supplanted heroin in most of the illicit markets in the country, and that's certainly true in our city and county and much of the state. It's very difficult, if not impossible, to find heroin anymore. Fentanyl was synthesized in the 50s by the chemist Paul Janssen. It's highly potent, and key here is that it's fully synthetic. There's no opium precursor. It's doesn't rely on any opium harvesting. It's a potent, a very potent agonist at the mu opioid receptor, about 50 times more potent than diacetylmorphine or heroin. And it's largely hepatically metabolized. And it has a similar half-life and receptor affinity to morphine, but it's very lipophilic, which accounts for some of its properties. It's as anyone who's experienced its medical use in the PACU, it's fast on, fast off when it's used acutely. However, with chronic administration of illicitly manufactured fentanyl, there is this accumulation in the adipose tissue that kind of leaks out into the serum, and this has caused some problem for folks trying to start buprenorphine, where you really want to have some much of the opioid out of your system when you initiate, and this kind of reservoir in the adipose tissue can sometimes cause complications where people, even though they've waited a long time since their last use, taking the buprenorphine can precipitate symptoms of withdrawal. It's also changed, and we'll get a little more into this. The pattern of use, we know from survey data, it seems to be different. People are using more frequently throughout the day. Because of the lipophilicity and and this effect on the kind of duration of action of the substance. The spread of fentanyl was really a supply side phenomenon. There was not necessarily a demand for an uber potent opioid, but some of the drug cartels realized in the 90s that the benefits to their business model. It's easier to produce. They don't need to wait for a growing season. That can produce vast quantities and with less land, and it's synthesizable from abundant chemical precursors that are in regular use in major industries. So really hard to regulate those chemical precursors. It's because it's so potent, it's easier to smuggle. It's easier to smuggle in a cigarette container size amount of fentanyl compared to a wheelbarrow of heroin, which would have the same approximate potency. And at least when they were initially distributed, it was in the form of these counterfeit pills, and still a large degree is that are kind of designed to look like oxycodone or Percocet, and this probably induced a larger consumer market because folks are a lot more comfortable in our society taking pills than using a powder or tarry substance, if they're new initiates in particular. And as the demand for heroin grew in the United States, fentanyl overdoses began to occur in 2013, mainly on the East Coast, and mainly admixed with powdered heroin. By 2015, synthetics like fentanyl surpassed heroin among drug overdoses nationally. And we were a couple years late, but in 2016, West Coast heroin supplies began to be supplanted by fentanyl as well. And as everyone knows, we're in the midst and still, unfortunately, on the upswing of unprecedented overdose epidemic in the country. And the last data from the CDC looks at a 12-month period from April 2022 to April 2023, and it's another grim record: 111,000 provisional overdose deaths during that time. So it looked like we had maybe crested the apex there, but we're still on the upswing. If you look at geographically, this is looking at that same 12-month period. Some states have lower rates of overdose compared to the year prior, and some in orange and red here have higher rates. And I have to unfortunately point out our little corner here is the darkest red of any state. We have a 34% increase from the year prior in terms of drug overdose, accidental overdoses. And King County represents a big portion of that. This is data from the King County data dashboard on overdose. And I think this goes through early September 2023. So we've still got 4 months. So I think we're on pace to continue this exponential rise of in overdose deaths. And just to orient you a little bit here, this blue represents deaths where their opioid is present in the absence of stimulant, and purple is opioid is present in the presence of a stimulant. And there is a sizable portion of folks where the overdose is attributed to stimulant without the presence of opioid. And when I'm breaking down the type of opioid, suffice to say that it's driven by these synthetics like fentanyl and fentanyl analogs. There's the ADAI, the Alcohol and Drug Abuse Institute at UW, has been doing some really interesting qualitative interviews to kind of understand how the change in the market is affecting people's use habits, perceptions, interest in treatment, et cetera. And they really describe this wholesale change from heroin to fentanyl, and a change in how they're using. So 82% of people, and these were people engaged at syringe service programs, only used fentanyl via smoking. And many of the respondents had many years of heroin injection history, but they had switched to smoking fentanyl due to fentanyl's potency and bioavailability by that route, and perceived lower overdose risk from smoking. This is a study out of San Francisco, basically trying to quantify from an early period of 2019 to an early period of 2020, during which time heroin was largely being replaced by fentanyl in the illicit market, looking at number of opioid injections over a month period, and versus in orange here, the days over the month of smoking fentanyl. And as more people were, as more fentanyl was being smoked, there were less injections in general. So, what are some of the downstream consequences? We've seen how the formulation of drug available on the illicit market affects medical consequences for people who use drugs related to the substance and the route. Well, what are some of the consequences of this shift? Well, we don't know. Certainly, there is a much higher rate of risk of overdose and fatal overdose. That's both among people who use opioids and among people who are opioid naive. Part of this story is that fentanyl is being incorporated into substances that are marketed as methamphetamine, as cocaine, as benzodiazepines. And folks without opioid tolerance are particularly vulnerable to overdose. Could we see? I don't think there's any data yet to bear this out. Could we, as injections decrease, might we see less bloodborne pathogen transmission? Might we see less endovascular infections, skin and soft tissue infections, and their sequelae? I don't know. Less opportunity to engage people who use drugs through traditional harm reduction models, syringe service programs. If are we going to lose that opportunity to engage folks? And then what are the implications for treatment? And we'll get to that in a minute. Just a quick word about xylazine. This is a veterinary analgesic. It's a alpha-2 agonist. It's kind of like an uber potent clonidine. And it's been increasingly seen as an adulterant of fentanyl in some communities on the East Coast. Philadelphia is kind of the prototypical one. It's in 90% of their law enforcement drug seizures of fentanyl contain this substance. And among other issues that it creates, like its own intoxication profile and its own withdrawal syndrome, they're seeing these pretty horrific necrotic skin lesions associated with use, and oddly, and not necessarily at the site of injection, and not necessarily in people whose route is injectional use. There's a lot of reports of people with these lower extremity necrotic wounds who use inhalationally or snorting the fentanyl xylazine by some unclear mechanism. And this has been detected yet not widespread yet in Washington State, and again, the prevalence of this and the effect on of this these chronic wounds on end organs, I think we obviously don't know yet. This is just a data from Millennium Health, a big laboratory that does a lot of urine drug testing for treatment programs nationally, and they are reporting on the percent of fentanyl positive urine drug screens that also contain xylazine in the last 100 days. So it's been 100 days since this was declared a drug of concern, and it really high in the mid-Atlantic region, as you can see, but as high as 4% in the Pacific region. And the DEA is concerned that it may well follow the same pattern as fentanyl. So folks are very concerned about if we're going to see the same type of encounter the same problems among people who use fentanyl as they are on the East Coast right now. So folks who have developed advanced CKD and have underlying opioid use disorder present real challenges, as is no surprise to anyone here. We know folks with substance use disorders have worse outcomes with dialysis. This is a retrospective cohort analysis from 2016 using data from the U.S. Renal Data System, looking at 500,000 incident hemodialysis patients. It wasn't entirely clear to me how they came up with this number, but drug dependence was recorded in 1.5%, and they kind of looked at outcomes data from that subgroup versus the control. And there was, in general, when you adjusted for everything they could adjust for, there was a 1.3-fold higher overall mortality and a 2.5-fold higher hazard of drug-sensitive death among the groups with the drug dependence. And if you look at this is the overall mortality hazard ratio, it's really stratified by age here. So if you were in a younger cohort when you started dialysis, your risk of mortality is as much as 2.5 times higher the hazard ratio is 2.5 for folks in that age cohort. And then, this really looking at the really terrific study from this group out of Harborview and UW, which in addition to really displaying the association between AA amyloidosis and intramuscular and subcutaneous heroin use, demonstrated some of the worst outcomes comparing this entity, AA amyloidosis specifically, to other causes of serious kidney disease, with faster rates of progression to end-stage kidney disease and higher mortality. This cohort in Bristol in the UK that I showed that the biopsy data earlier, this is just a small group of 23 patients, but they really present a lot of the details that I thought might be of interest. That they had particularly poor outcomes for folks with a medium time from progression to dialysis of 47 days from presentation to hemodialysis. 18 patients out of the 23 started hemodialysis, 5 started peritoneal dialysis. The outcomes for peritoneal dialysis were pretty abysmal. They transferred to hemodialysis after a median of 52 days, and I think that institution, they said in the discussion, they no longer offer peritoneal dialysis for the most part for folks with ongoing injection drug use. And you can see that the access is primarily by catheter, and median number of catheters required was 2. And the reasons for exchange or removal are as follows. A quarter were complicated by infection or occlusion, and then 15 of the 23 died during the data collection. It was a 65% 1-year survival among that small group, versus much higher rates of 1-year survival for incident dialysis patients in the country at large. Causes of death were unknown for the majority of patients. Infection, withdrawal from dialysis, cardiac arrest due to hyperkalemia, and then 2 drug-related, fungal endocarditis and overdose. Just a short list. I'm sure everyone here could add several items to this list, but these are really challenging patients for a lot of reasons. We talked about the late presentation to care, which complicates many things, including options for access, the technical challenges and fistula formation, and the risk of infection or occlusion of dialysis catheters if folks are using those as portals for drug use, adherence to dialysis, adherence to kind of nutritional dietary changes, the high burdens of the treatment for end-stage kidney disease and opioid use disorder, the way that our system currently operates. All the comorbidities that are overrepresented in folks with opioid use disorder, and how that interplays with some of these access questions. And then systems issues like access for inpatient or residential drug treatment. They really get it on both ends. Folks on if they're on medication treatment for opioid use disorder, this is getting a little better, but it's still some inpatient residential facilities will not accept patients on medications, particularly methadone. And then even more common are folks with they're not equipped to handle folks with complex medical comorbidities. Dialysis being the prototypical example of that. Just to drill in a little more to a challenge that everyone's familiar with, just one of those challenges is transportation. I thought this was an interesting letter to the editor, looking at this region in Ohio, Virginia, West Virginia, and looking at drive times to an opiate treatment program, the only outpatient facility where methadone can legally be dispensed, and dialysis. And it, the point of this letter was, look how bad access is, look how far transportation is for opiate treatment programs. But in the context of this discussion, imagine if you had to travel to both, six, 7 times a week for opioid treatment programs to get their dose, and 3 times a week to dialysis. The burdens of treatment for both conditions are very high, and beyond the capacity of patients in the midst of oftentimes in the midst of crisis. Please feel free to jump in while if there are questions about anything, but also happy to have discussion at the end. So just a reminder, the good news, there are effective treatments for opioid use disorder, particularly when compared with other substance use disorders and behavioral addictions. Methadone, buprenorphine, depot, naltrexone. I give this one an asterisk because there isn't the robust data on reduction in mortality that there is for methadone and buprenorphine, but it does appear to reduce illicit opioid use. But there is, decades of data demonstrating the pretty profound impact on survival for folks on agonist treatment for opioid use disorder, effect on retention and treatment, employment, reduction in opioid use, reduction in associated infections, reduction in criminal justice involvement. These benefits, particularly, this has been well displayed with the survival, accrue with time and treatment. And that's one of the challenges here. Often there's no, I don't think there's a typical kind of path for folks initiating treatment with an opioid use disorder, but oftentimes there's a kind of stuttering progress where folks may engage in treatment for a time, return to use, return to treatment, maybe a little bit longer, accrue more benefits, more recovery capital, return to use, and that pattern kind of continues until they're really able to sustain a long-term engagement in treatment. And when you have a life-limiting comorbidity where that depends on you stabilizing rapidly in order to engage in that treatment, you don't have that. You can't follow that treatment course. Medications for opioid use disorder are effective for fentanyl, but there's new treatment challenges. That it's more difficult for folks anecdotally to tolerate fentanyl withdrawal. I already mentioned there's some concerns that reports of people experiencing more precipitated withdrawal, which trying to start buprenorphine. It's a little harder seems like it's a little harder for folks to start buprenorphine than when heroin was the predominant opioid on the market, and higher doses. This isn't yet borne out in the literature, but it's certainly true at Evergreen Treatment Services and at other opioid treatment programs I've talked to. Higher doses of methadone and buprenorphine are required on average to control cravings. And one of the challenges we have in the methadone side of things is we're really limited by the regulations and how much we can give when someone first comes to treatment, and it's just inadequate. People don't experience the benefits early on in treatment, and we're losing people to treatment pretty early for that reason. It takes time to get to a therapeutic dose, and it's seemingly with fentanyl, people are less able to tolerate that period of time of med titration, and that's a real problem with retention. Um, we really want to think about the gap in treatment. There's still a lot of people who could benefit from treatment who have not had access to treatment or not engaged in treatment. And this is a study from last year, estimating based on survey data and a modifier that accounts for some of the lower numbers they see on these household surveys. That there's about 7.5 million people with past year OUD in 2019, and about 1 million had access during that year to or were exposed that year to medications for opioid use disorder. So that's 86% of people with moderate to severe OUD who could benefit from treatment did not receive it, and Washington is a little behind the 8 ball there. It's even a higher number. You can see on this graph, it was in, this is the number of people receiving medication treatment for OUD. So it is increasing at a steady clip. And in 2015, buprenorphine, this kind of line here surpassed methadone, but folks are increasing treatment with both those medications. And just quickly, I want to make sure we have time for discussion. There were some, as I alluded to, some changes in regulatory policy, both in response to COVID and the unprecedented overdose crisis, to try to expand access to treatment that it's good for folks to be aware of when treating patients with an opioid use disorder. So I think folks are aware that the X waiver that was required since 2002 to prescribe buprenorphine was lifted at the end of 2022. So any prescriber with a DEA license can prescribe buprenorphine now. There's no caps on how many patients you can prescribe it to. It's just a regular Schedule III medication in that sense. You do need to undergo this 8 hours of education to apply for a DEA license or renew your DEA license. You need to attest to that. So I guess in a sense, they made everybody have to do the training, which I think is a good thing. But that barrier, that this medication can only be prescribed by a subset of patients who've undergone special licensure is gone. And telehealth, the Ryan Haidt Act, really stipulates very specific circumstances in which you can prescribe a controlled substance like buprenorphine for somebody if you're evaluating them remotely via telehealth. And that was, a lot of those provisions were suspended. So it was allowed to prescribe buprenorphine based on telehealth or in fact telephone visits. That leniency is in place till the end of this year. And DEA is coming up with, and they're asking for public comment about what the rule is going to be going forward, and there'll probably be some rollback of that you need to have an in-person visit within 30 days or something like that. But it looks like there'll still be some more flexibility around remote initiations of medications for opioid use disorder compared to before the pandemic. And there's, just through efforts of healthcare authorities and certainly in our state, more access to coverage for injectable buprenorphine, which is a really great tool in the fentanyl using population. You achieve much higher serum levels of buprenorphine, and the adherence is easier for a lot of patients to get a monthly subcutaneous injection rather than take their medication every day. This hasn't been studied rigorously in folks with advanced CKD or folks on dialysis, but there's accumulating clinical experience. We have a couple patients at Adult Med, I believe, on the lower dose injectable buprenorphine who received dialysis. And a couple changes at opiate treatment programs. These are the highly regulated entities that are permitted to dispense methadone. The regulations have been largely unchanged for 50 years, particularly when it comes to anything that would touch the patient or how care is experienced. And the standard throughout that time, those 5 decades, was observed therapy for much of treatment. Certainly the early part of treatment, where folks would come 6 or 7 days a week to have their medication administered directly and observe the ingestion until or unless they can demonstrate very stringent criteria of stability, and had spent a long time in treatment. And that underwent these substantive changes when COVID hit, and rightly so. There was concern about opiate treatment programs being kind of hubs for infection, people coming from various other communities, waiting in crowded waiting rooms every day and dispersing. So there was a lot more leniency given to providers to make independent medical decisions about how much medicine was safe for a patient to take home, and a lot of variability in how that was applied. But the data from that period is coming in, and it looks like I think I have a slide on that coming up, so I'll save it. But they've codified some of the changes now so that there's more access for take-home medication earlier in a patient's course of treatment. And they've also made it easier to license and fund mobile medication units to bring methadone out of the brick and mortar opiate treatment programs and into community settings. This is just an example of the old regulations around time and treatment. You had to dose in the clinics 6 days a week for 90 days in the old system, and meet a bunch of other stringent criteria before you had the ability to get an additional take-home dose of medication. It would be a year of that before you could get 2 weeks worth of medication. The new regulations, as you see here, you can get a week. You can get up to a week when you first start treatment. And by a month into treatment, you could be eligible for 28 days of treatment. So really a dramatic difference in the regulatory framework. How that's going to play out for individual clinics and their policies, I think, is an open question. And we saw, there's a lot of data coming in now. We saw that the sky did not fall when people were given their medication to take on their own. Rates of methadone involved deaths among OTP patients did not have a noticeable increase, nor on the population level as a fraction of total opioid overdoses. And then some data suggests that improvement in retention and reduction in treatment interruptions among patients who were granted more access to unsupervised medication. So I think that is I think this minimally disruptive medicine framework is an interesting framework to use in thinking about opioid use disorder treatment. Really kind of applying this rubric. Researchers are applying this rubric to diabetes care, all sorts of care models, but it really, you look at what's the burdens of the treatment and what's the capacity of the patient to face those burdens, and how that interplays with adherence to care. And the burdens of OUD treatment are very high in our current system, and the capacity, because of all these co-occurring medical and psychiatric and social issues that we've discussed, is often low. And so leveraging the ability to reduce what it takes to engage in treatment, I think, could go a long way. And when you think about a patient with advanced CKD, it's even more important. That's not a care model that can easily be reformed to have a lower workload for patients. But the opiate use disorder treatment system certainly is. So how can we minimize these treatment burdens? So patients with serious medical comorbidity, certainly, and maybe patients more generally can have more access to unsupervised medication. Could telemedicine be utilized for patient engagement? For patients for whom there are safety concerns for unsupervised medication access, could medication be provided at dialysis, either through some of these newly licensed mobile methadone dispensing units, or there is this mechanism to utilize a chain of custody to transmit methadone to another credentialed healthcare practitioner, and that we utilize with nursing homes and inpatient facilities and residential treatment. And I don't know of anywhere that's doing this in the country, but I think I don't think there's any regulatory barrier for a willing dialysis center and a willing opiate treatment program to partner in that way. And there really continues to be a silo, I think, between behavioral health providers and medical providers, in part because the substance use disorder folks are beholden to a higher confidentiality standard than HIPAA. But it just takes a release of information to allow coordination that can be really helpful between the nephrologist and the addiction provider, for example, and someone who's getting care from both. This is my dreaming: intensive early case management, I think, on behalf of an addiction a behavioral health agency for patients with substance use disorders and serious medical comorbidities, to help with all of the coordination that's required to treat both those conditions. And then more, we need more access to inpatient and residential drug treatment facilities that can accommodate people with serious medical illness. And then just a word, we could spend a lot more time on prevention. I really appreciate Dr. Hazley has really been terrific in educating the staff at Evergreen Treatment Services and our OBOC group on the risks of this entity of amyloidosis, and providing some patient education materials. We need to do all the good work of harm reduction, reduce HIV transmission through syringe service programs, but also PEP and PrEP provision for folks where that's their risk factor, which is very low uptake of that practice. Hep C testing, treatment, and elimination in drug treatment settings. Safer use counseling and supplies for reduction of skin and soft tissue infections. A lot of the syringe service programs, were developed, mandates to reduce viral transmission. There was a lot of emphasis on not sharing syringes, a little less emphasis. Our syringe service programs are terrific about this, in talking about safe injection, sterile practices for injection, and then early treatment of SSTIs, of skin and soft tissue infections, which would require low barrier routine healthcare for people who use drugs, which is a challenge. Counseling on injection reduction or cessation. I think this has long been a tenet of the harm reduction counseling, but that's been to a large degree unsuccessful. But with the bioavailability of inhaled fentanyl, I think it actually is probably as we've seen from some of that survey data, an acceptable alternative for some folks using a fentanyl. routine screening for proteinuria among people who use drugs. We don't know the utility of that from any studies, but is that something we should engage in to identify early folks who may be developing kidney disease? And then, of course, expanding treatment opportunities and enhancing engagement in treatment. And this is a study that's coming out of that recruiting in the UK. At least I couldn't find that it's been published yet, but they published their kind of study protocols, and they're trying to recruit 400 people who inject drugs in London, and trying to get at this question: what's the feasibility of amyloidosis screening and referral among people who inject drugs? What are the barriers and facilitators to care for that population? And then how can we reduce risk and encourage harm reduction? So I'm looking forward to that, the outcomes of that study. And that's all I have, and I went longer than I intended, but I want to make sure there's plenty of time for the next discussion. But I do want to make sure if there's questions or comments to address them.
Thanks so much, Jamie. And of course, thanks for doing your work with this population of people with incredibly difficult health issues. I really like that model of minimally disruptive medicine. I have to look into the details. I can say pretty confidently before seeing all the small lines on that diagram that dialysis probably doesn't align with that philosophy in a lot of ways. And people who are engaging in dialysis, this system, and also system for opiate treatment disorder separately, really intensive programs is incredibly challenging, and maybe especially distressing to us since we've built these systems. So hopeful that some of those potential future changes that you're suggesting could improve care for these folks. Question from Dr. Mrotra.
Thank you, Jamie. It was extremely interesting talk, very thoughtfully put together. Thank you for speaking to us. You talked about injection drug use. A related issue is prescription opioid use. In the United States, some 20% of people on dialysis have more than 90 days of opioid prescription provided to them. And my first part of it is a comment. We are doing the NIH is leading this clinical trial. We are a part of that. We have randomized 640 people with chronic pain, with or without prescription opioid use. And one of the outcomes is the intervention is cognitive behavioral therapy. And the outcome is one of the outcomes is reduction in prescription opioid use. So any thoughts in that regard? And then second one was more about the safety of methadone. Maybe if we could also add, there's an arm to the trial, the HOPE trial that I just alluded to, where people that have a high enough MME would be offered BUP. But there are not enough people with high enough MME to be given BUP, so there'll be less than 10 people that get BUP in the trial out of 640 people. But the safety of methadone with increasing QTC interval, and 50% of people on dialysis have a prolonged QTC to begin with. Any thoughts in that regard? Any concerns in that regard?
Thanks so much for the question and the comment. Yeah, first for the on the point of the prescription opioid dependence, I totally agree. I mean, there was in the 90s, and there remains a real problem with chronic pain, and we've really shifted tack as a medical community in our approach as relates to opioids, but I don't think we've yet developed a much harder fix of how you can really effectively address chronic pain with some of the more intensive interventions like CBT, mindfulness-based therapy, and so I really am excited to hear about that study among folks with a much higher baseline rate of chronic pain, and all the complications that with analgesic use that come from having CKD. As far as methadone in dialysis patients, the QT interval, I was going to include a slide on it because it's something we do struggle with. And folks, with the I think there was a study really looking at just the variability among QT interval for folks on dialysis at different stages in dialysis, post-dialysis, pre-dialysis. So it's an issue. We really try to approach those issues on prolonged QT in a patient-centered manner, where we acknowledge that yes, they may have a marginal increase in the risk of a malignant arrhythmia, but particularly in folks who have failed alternative, or I should say, where alternative treatments have failed to stabilize them. What's the risk of adverse outcomes from reducing their methadone or trying to transition to another opioid? And usually, unless there's a patient who's actually experiencing symptoms, or their risk is astronomical because of a very high QT, and if we've taken all our precautions to eliminate other meds that are not necessary that may prolong the QT, counsel the patient about, because I in my experience, the way patients really get in trouble is if they go to the emergency room and they get a macrolide, or they get another hit. So really counseling the patient about, don't start any medication until you talk to us or your other doctor about it. And so trying to understand that there is this marginal increase of risk of an arrhythmia, but weigh it against the risks of decreasing the medication. But in thinking about designing a protocol where you introduce methadone in that population, I guess that's not the question here. Buprenorphine, there is not that concern, as with the QT. So I think that having that be an option for folks with high MME makes a lot of sense. Me personally, and some of the data I've seen, I think it's a great analgesic option particularly for folks who don't respond particularly well to high dose full agonist opioids. So I'm really excited to see the outcomes from that study.
Jamie, I'm sorry to have to abbreviate the discussion because I know there'll be a few more questions. Raymond, I see your question in the chat. Did you have a quick question that you unmuted for? Okay, all right. I was wondering about that question about the mechanism of xylazine as well. Maybe if you know anything about that, Jamie, you could add to the chat. And maybe if you're able to stay on, depending on your schedule, until after the end of the next presentation, maybe we could continue the discussion then. But thank you again for coming and talking with us.